We're going to move forward with gram patch for this presentation, but something I was trying to, I guess, try to find in the literature is there a clear size cutoff for gram patch versus thal patch? And the only source that I could kind of follow the path down was a question from SCORE, which then referred to Stabistons that said there's a 2 centimeters or less look to do a gram patch, greater than 2 centimeters do a thal patch. And so I talked with Dr. Robick about that, and he kind of led on that maybe there's more of the surgeon's inclination of, I get in there, I see this ulcer. Now, do I think that, yeah, it's encroaching on 2 centimeters, but the margins aren't looking very good? Maybe I should, appreciate this as a larger perf versus a smaller perf in deciding to do a thal versus a gram. But for this gentleman, we'll move forward with a gram patch.
Anybody on any Dr. Hetz, any Golden, any of y'all ever done a thal patch?
I've never done a thal patch on somebody that's had a perfed ulcer. I've always done a gram patch. I must admit, I don't think I've ever had a ulcer perforated that was greater than 2 centimeters in terms of the holes. As a matter of fact, typically the holes are almost perfect little round punched out things that are in the zone of about 5 to 7 millimeters in size. It's very typical, and they seem to be pretty amenable to a gram patch, frankly.
In trying to review and look up stuff on thal patch, the only time that I found perforation was iatrogenic, doing a EGD or something and perf the duodenum or something that was greater than like 1.5 centimeters. To just kind of further support what you're saying, sir.
Interestingly, let me interject. I have done thal patches a couple times actually in the setting of marginal ulcers for gastric bypasses, after gastric bypasses. And the thought there is that even if that sort of erodes into the roux limb or whatever, you just take up the roux limb and sew that around to where that ulcer is. It still is just a continuation of the roux limb, and so you don't lose anything in terms of losing nutritional status or things like that. You also can do it with the stomach, and so you can wrap the stomach around a marginal ulcer. And so if you have a perforated marginal ulcer, you can take the remnant stomach and stick that and sew that around the ulcer, and then continue that up to make a gastrostomy. And so those are two things in fellowship that we did for perforated marginal ulcers that I hadn't seen before, but worked very well.
In moving forward, patient goes rise in the OR. We set them up supine, arms up in T position or crucifix position. Patient is going to be prep and drape in normal sterile fashion. We're going to provide local at the supraumbilical position, putting in a 10 millimeter trocar, starting with a diagnostic lap like many of our other procedures. Primarily for this one, what we're looking for is bilious drainage and succus across the abdomen, and then adhesions based on potential history of disease. Next, we would place 2 5 millimeter ports to the left and right of our initial supraumbilical port, mid-clavicular line. We're going to take a suction irrigator and aspirate fluid and send that for culture prior to moving forward with the procedure. After aspirating the fluid, we'll go ahead and put the patient in head up, left up position. Potentially use a 4th port at the anterior axillary line just under the left side intercostals, and then possible liver retractor or Nathanson retractor subxiphoid position for better exposure. We'll inspect the stomach and duodenum for ulcers, which most commonly occur on the anterior or anterior superior aspect of the duodenum and stomach, looking for the body to potentially have made its own natural gram patch. Quick sidebar from that, the literature I reviewed on that, it seems that I think it's better to take down the body's natural gram patch and put your own in place. I know there's kind of some back and forth on that, but put your own in place and secure it. That way, I think I'd feel more confident in my intervention than just leaving the bodies and stepping out. But I don't have much experience, so I can't say too much on that. But with attending assistance, I think I'd feel better after my surgical intervention. So we've identified the perforation. We'll then bring in 3 to 4 2-0 or 3-0 vicryl sutures, placing those approximately half a centimeter apart across the perforation. Not securing them down yet. We'll then find a healthy tongue of omentum, bring that up, and secure that down snugly over the perforation. Afterwards, we'll perform an air leak test to ensure that it's snug enough not to come dislodged, but not too tight. We'll then place a drain near or along the gastrohepatic interface. We'll do copious irrigation throughout the abdomen until it runs clear and is suctioned out. Afterwards, we'll desufflate, remove trocars, and follow up on patient post-operatively. Something else to bring up in regards to possible surgical intervention is the modified Graham patch. And the modified is on your left, or image A, and then the Graham patch is image B, in which with your initial throws of suture, you approximate the edges of the perforation first, secure that down with a knot, then bring in a healthy tongue of omentum, securing that secondarily over top of that in the same snug-like fashion. And so some of the articles that I had reviewed, one being an 80-patient comparative analysis of the Graham versus modified Graham, looked at outcomes to assess which was potentially better. And what they found is there was really no significant difference between the two repair techniques. The only big difference was increased operative time for the modified Graham patch, and then increased length of stay for the original Graham patch, the 1937 version for the Graham patch. Otherwise, we'll have the patient admitted, monitor for post-op.
Hold on, Brandon, let's talk a little bit about the operative technique. Has anybody ever done a laparoscopic Graham patch on the net?
Yes.
A couple of people, okay, good.
Yes.
You know, I think it's good if it's been early perforation, but if it's it seems to be a little bit later, it's really hard to get a good irrigation of the abdomen. Let's see, Dan, next year, what are you going to do as far as how are you going to set up your Graham patch? So say we're doing it open. How are you going to repair the defect? Are you going to use the modified or the standard Graham or some different type of omentopexy?
Yeah, so it'll depend obviously on how much tension, because having done a few of these, I realize how friable all the tissue can be. And obviously, you don't want to make the hole bigger in an effort to close it primarily. So if it's a pretty punctate one like I'm used to seeing, what I typically like to do is throw a stitch, leave each tail, like pull the suture about halfway either side, tie it down primarily, and leave each tail long. Do as many primary closures as I need, leaving each tail on there, and then flap up a pedicle of omentum, and then use my tails on top of that to tie it down, kind of like what they're illustrating there.
Yeah.
I've seen some people where they do 2 separate sutures, one to primarily close, cut it, and then do a separate suture, but I guess I don't see a huge advantage to that. But yeah, I'm more of a modified Graham guy myself.
Yeah, we tried to do this laparoscopically, doing the modified, and it is kind of difficult, especially if you're not freehanding it, if you use the endo stitch. I mean, obviously you can't just leave the tails there. It becomes kind of challenging. We struggled with it for a while, but if you're using an actual suture needle, that you can do it potentially the same way you would do it open with a modified, where you kind of tie it down, leave the tails long, and then go back and try to do it. But then you're tying laparoscopically with long tails, which is its own kind of pain.
Yeah.
The last one it'd be very difficult to do it with endo stitch. I don't know how. That would be
I was going to say, just given the fact you have a straight needle is difficult. But yeah, the last one we did was laparoscopic with the curved SH needles. And yeah, it was a little painful trying to manage the tails and everything like that, because they all want to get intertwined, especially when you're intentionally keeping them all long. But
so the way that we ended up doing the endo stitch was just doing 2 separate sutures, primary, and then go a little bit further out and just kind of taking a bite of healthy tissue and having the assistant hold the omentum up and then tie over that. That was the way we finally got around it, just 2 separate stitches.
Yeah, just my 2 bits, because I'm the MIS fellowship guy, is two techniques. One, you don't do anything to try to close laparoscopically. You don't do anything to try to close the hole itself, and you'll go either with the endo stitch or with the free needle. You can go and almost do like a limber, and you go way outside of where the perforation and inflammatory field is, which is really dependent on what Dr. Bell said, how early or late it is, because that tissue is really friable. And if you get a really big bite, then you can make this hole just this ginormous hole and a big problem to deal with. So you have to have a little bit of judgment. But if you go outside that inflammatory field and almost do a limber, so you're getting full thickness, which is not like a limber, but you're getting full thickness duodenal bites on the near side, in and out, and then you cross over and then go in and out on the other side of that and leave your tail long and have your omentum over the top. Then you can tie that down just enough so that you're not tearing the tissue, but you're enough that you're holding the omentum in place. And so you can do that either with a free stitch, or you can do that with an endo stitch, depending on what you're trying to do. As far as the management, I think laparoscopically, the management of the tails, which does become an issue if you have long tails, that's 100% dependent on the surgeon that's doing the case. So what you can do is in terms of managing the tail, you take, you go through the omentum, you'll go through the omentum first, and you'll go through twice. So you don't, and what that does is that binds that suture up wherever you need it. Mm-hmm. And so that keeps your tail as long as you need it. And then as you drag that up, and your assistant can help you, that suture won't move because you've gone through the omentum twice. And then you do whatever management you need to do with the ulcer, and you go back to where that was through the omentum and tie that down. So those are just kind of management issues, minimally invasively, that you can do to help minimize the struggle that it is in the OR. I think a lot of times when I hear, these struggles like, oh, we can't do this, this is best doing open, it's usually people that typically do a lot of cases open and a lot of their emergent cases open. And so it's just, they don't do a lot of laparoscopic sewing. And so some of these tricks are difficult. The other thing you can do, if you don't want to go through twice the omentum first and then address the duodenum, you can go once to the omentum and then stick a clip on your stitch, and that'll hold that also somewhat in the omentum too. Obviously, it depends on how bulky your omentum is, how much stitch you need to do, and how much kind of wraps through the omentum to manage that omentum. The nice thing is that the omentum's nice and big and bulky, although it's hard to keep the stitch through there, it also is a good bolster for your laparoscopic kind of tension on the duodenum. Those are my 2 cents.
Yeah, the way you describe the repair laparoscopic is usually how I do it open. I do a limber on each side of the hole and then create a tunnel of the suture. I think maybe Kara or Bethany did one of these with me at Del Sol. Somebody did one with me at Del Sol a couple of months back. But I create a tunnel and then slide the omentum underneath. So it's kind of like the modified gram patch, but there's no, I don't like tying the suture down over the hole, so it approximates it and slaps the omentum down on it. So I pulled some of my friends last night of how they did it, and they do it the same way, but we all train the same way, so that's probably why.
Hey, Brandon, I have a question. I may have missed this. I lost the signal for a few seconds there. But was there anything else that you would do with the ulcer before patching it?
So some of the things that they talked about is possibly notifying GI and doing endoscopy, getting biopsies of your margins and ulcerative base and sending those down for follow-up. Perfect. Is that where you're going?
Yeah. That's what the cancer guy was wondering.
Gotcha.
Hey, I had a question. I was curious how many people do leak tests. I've done a couple of these and I've never done a leak test. I'm just curious how many people have done leak tests at the end of these.
I personally have never done a leak test. And I think that what Dr. Nelson said is probably the most important thing is taking a biopsy. but I've never done a leak test. I've diagnosed 2 gastric cancers from doing biopsies in the last 2 years.
The other thing too is oftentimes with these, you're doing combined endoscopy at the same time. And so you can look and localize where that ulcer is and that perforation. You can get biopsies from the inside and the outside. Usually your inside biopsies are more diagnostic than biopsies from the outside.
So moving forward, just post-operative follow-up then. If we did the H. pylori testing, we're going to want to make sure we follow up on that. Some of the literature I had read up on said you could just start treatment while they're there admitted and then continue them on the course and then follow up the results. I think I'd be more inclined to do that just in case patient is lost to follow-up or something. At least I feel a little better saying I gave them treatment before I had lost them and was unable to follow up with them despite continued attempts. Something else we'll do is refer them to primary care. I had talked about that earlier. This gentleman was on NSAID therapy, so we're going to need him on something as an alternative to his NSAIDs so that we eliminate that as a contributing factor for future ulcers. And then the biopsies, which we had just mentioned, that were either performed intraoperatively or if this was an outpatient basis, that we'd want to follow up on for possible future indications for intervention.
Brandon, you said you were going to get your H. pylori test with either fecal or urease breath test. Hey, Jen Cooley, why didn't he just do the serum test for H. pylori? He got a bunch of other labs in the ER. Why didn't he just have them throw that on?
I believe the serum test will show if you've ever had H. pylori, and these ones show if you currently have it.
Yeah, exactly. The urease breath test is your test of cure, but your fecal antigen is going to be the one that's going to show your acute phase. The serum is just going to be positive. So absolutely right. So that's commonly missed because it's in the order set. So just be careful.